industry has donated drug to the trial, but they are all NIH-funded trials, and much of what we do in uveitis is off-label. So comparative effectiveness trials compare treatments to determine which is better, to help inform us in the management of our patients. The MUST trial, which you've heard mentioned, was a multi-center trial comparing the fluocinolone acetonide implant to a regimen of oral corticosteroids and immunosuppression. It asked the question of which is better. It originally was designed to go for 2 years, but ultimately went for 7 years. And what we saw was that at about 6 years, there began to be a difference between the two as patients in the fluocinolone arm began to relapse, and that led to a difference in the visual acuity between the two groups. And indeed, one can see that with the fluocinolone acetonide implant, there was a doubling of the risk of blindness to 22%. Conversely, that difference was due to chorioretinal lesions that occurred in the context of relapse of the uveitis. Conversely, other than a greater use of antibiotics in those given systemic therapy, there was no increase in systemic side effects, in part because of the treatment algorithm, which drove the dose of prednisone down to an acceptably low level and encouraged the use of immunosuppression to achieve that. We also see that there are the anticipated difference in ocular side effects, but perhaps surprisingly, an almost 3-fold greater risk of glaucoma in those receiving the implant. The implications are straightforward. Systemic therapy appears to be the better initial choice if used properly. The implant does control inflammation better in the short term and may have role for those where systemic therapy cannot be used or where it is ineffective, but at a cost of more ocular side effects, and it highlights the problem with the primary regional approach, which is the variable duration of effect and relapse before re-injection or re-implantation with subsequent damage to the eye. In the MUST trial, as noted, about 2/3 of the patients in the systemic group need a regional corticosteroid injection to address the macular edema, with the median number being 1 and 75th percentile 2. Also note that at 2 years, 40% of the edema had not resolved, and we'll come back to that. That led to the POINT trial, which asked the question, what is the best way to approach the treatment of uveitic macular edema with short-acting adjunctive therapy? And the 3 options were periocular triamcinolone, long triumphed by uveitis experts, intravitreal triamcinolone, long triumphed by retina experts, or the intravitreal dexamethasone implant, Ozurdex. The results here show that the 2 intravitreal therapies were similar. All 3 were effective, but the 2 were similarly better than periocular therapy in terms of resolving the macular edema. And if you look at the graphs on the right, you can see both the top and the bottom, which are improvement and resolution. The 2 intravitreal are superior. The apparent improvement with periocular therapy after 12 weeks is not due to the effectiveness of periocular therapy, it's due to the allowing those people to escape to intravitreal therapy at that junction. One here can see just the comparative numbers. So numbers less than 1 indicate superiority of the drug on the top. The dexamethasone implant appeared to be perhaps slightly better than intravitreal triamcinolone, but it was not statistically significant, and the conclusion is that it was non-inferior or similar. A surprising result was that those started on periocular therapy, despite being allowed intravitreal subsequently, never quite regained the same vision as those started on intravitreal therapy, and it is my conclusion based upon that intravitreal is indeed superior and should be the initial approach. There was a greater risk of elevated intraocular pressure in the POINT trial with the intravitreal therapies, but there was a similar risk of high rises of intraocular pressure to greater than 30 among all 3 groups. And surprisingly, perhaps Ozurdex, which had been thought to have less of an impact on intraocular pressure, was no different from triamcinolone. The implications are straightforward. Intravitreal therapy is probably a better initial approach. You can choose between the 2 drugs, triamcinolone or Ozurdex, and they are similar in efficacy and in terms of side effects. Now, we saw some of these data earlier. It has to do with what to do with that 40% who do not resolve their uveitic macular edema. Note that in the table up in the upper right, the 2nd injections and 3rd injections of steroids do have additional benefit. We know from what was shown that intravitreal anti-VEGF and intravitreal methotrexate also have benefit in the management of these diseases, all appear to have benefit. That led to the MERIT trial, which is a randomized controlled clinical trial of intravitreal dexamethasone versus intravitreal ranibizumab versus intravitreal methotrexate for recurrent or persistent uveitic macular edema. This trial is currently ongoing and is about 55% recruited. Here are the clinical centers, which are in the United States, Canada, Australia, United Kingdom, and soon, hopefully, in India as well. Now, drug licensing trials often compare the drug to placebo. And here we can see the two trials that led to the approval of adalimumab for uveitis. They showed that it was very effective against placebo for both active and inactive uveitis. But these two trials used a rapid taper of prednisone to discontinuation, which is not what's done in clinical care, and you have no comparative effectiveness of adalimumab versus standard therapy. That led to the ADVISE trial. The outcome of the ADVISE trial is a prednisone dose less than 7.5 milligrams a day and control of the disease. Why? Because that dose is safe for a period of years, but perhaps not decades, because we do see an increase in cardiovascular disease with the cumulative dose of prednisone. Visual 1 and 2, as I showed you, were drug licensing but have no comparative data, and preliminary data based upon the Visual 3 study and the SIGHT study suggest that adalimumab may be superior to the conventional approaches for the treatment for corticosteroid sparing. That has led to the ADVISE trial, which is a straightforward randomized comparative effectiveness trial. The trial is now enrolling, and the first 3 patients have been enrolled. It has, I won't go through the treatment schema, but basically there is a defined treatment schema based upon the sort of order of drugs used in the MUST trial. There is a unique, innovative feature of this trial, and that is, if you look at the tests on the top, they are standard for all patients. But patients on the bottom are getting disease-specific testing based on the disease that they have in order to evaluate that specific disease. And inactive disease is being judged based upon the disease-specific testing. So as we see here, fundus autofluorescence is useful for those with choroiditis, but not that useful for those with an exudative detachment, where we'll be using OCT, as in this patient with early VKH, or fluorescein angiography for patients with retinal vasculitis. And so this is an innovative feature of this trial. The trial, as I mentioned, is ongoing in the United States, Canada, Australia, and the United Kingdom. And we hope that we will have results within the next several years to help guide therapy for the management of uveitis. So what can we say about comparative effectiveness trials? They shape clinical practice. They are important to tell us how to do what we do. The results might be surprising. We learn things we didn't expect about IOP in the POINT trial. The results might lead to new trials, such as the MUST trial leading to the POINT trial. And they cannot be done without the NIH funding, which I credit here on the slide. Thank you very much for your attention.